An educated man knows how much he doesn't know. Once you think you know everything, that's the beginning of you going down. Then, nobody went from 0 to 100 in 1 second. It takes time.
It's very fascinating that you're overseeing now more than 3 decades of evolvement of implantology.
Fear and anxiety comes from lack of knowledge. And once you have the knowledge and you understand how it works, the fear and anxiety goes away.
So you had this, let's say, beautiful combination of teaching and practicing as a clinician from the beginning, since today.
Absolutely. Well, my entire basis of thinking is based on biomechanics. No matter what you do, there's occlusal forces that are being placed on whatever it is that you're reconstructing. Most people expect the answer to be yes, but I think my mindset always was anything that's said to me, I ask the question why.
Welcome to ProTalk. Welcome to the Pulse of Dentistry. And today in this episode, George and myself are very happy to welcome a maxillofacial surgeon by training and someone that has been very active in the pioneering times of implant dentistry and was bridging it over to the modern field of especially very complex work in atrophied maxilla situation. Welcome, Professor Dr. Ed Bedrossian. Welcome, Ed.
Thank you. Thank you for having me.
Thanks for coming all the way over from the US. It's our pleasure to have you here today in Basel. And today in this episode, you will learn about the mindset that you need to have to approach these type of very complex work. You will learn about zygomatics, about immediacy, and of course, how the future will carry these topics forward. So great to have you, Ed. And to start with, and before we dive into the mindset and the technique and everything that you brought to implant dentistry, who is Ed Bedrossian in 1 minute?
Well, as you said, I'm a maxillofacial surgeon by training. I grew up in England and came to the US after high school and did all my training, college, dental school, oral surgery residency in San Francisco area. So that was very convenient and good. I decided to open my own practice from scratch. So my chief of my program started to laugh when I said that. I said, "Why are you laughing?" He said, "You're going to start from scratch, all the competition?" And I was young, so I said, "So what shall I do?" He said, "I think you should come and teach." I said, "Okay." So from day one, every Monday for 30 years, I was at the residency program and 4 days in private practice, and have been involved with education and private for my entire career.
So you had this, let's say, beautiful combination of teaching and practicing as a clinician from the beginning, since today.
Absolutely. I think if you are involved in that kind of an environment, everybody thinks you are doing a lot of teaching, but really you're doing a lot of learning. Mm-hmm. It forces you to stay on subject. Mm-hmm. So it's been probably more beneficial for me than it's been for anybody else that has been interacting with me. Yeah.
Mm-hmm. And let's go back to right the beginning of your career. How did you decide to become a dentist, or to be precise, a maxillofacial surgeon?
Yeah, that's very interesting because in England, they have a system where everything is based on Oxford and Cambridge. So when you're 12, you have an interview. They decide if you're going to go into arts or into sciences. So I decided to go into sciences and I don't know, it's just dentist when we're talking to the family, because you're a doctor, but you don't have to deal with life and death. It's, safer, much more comfortable life. So it was just like a child. Okay, that's what I'm going to be. So when I went to dental school, the first week I enjoyed what they were teaching, but not very much. So, and from cultural background, you've been a dentist since you were 12. They called you a dentist, right? So I looked for what else is interesting, and the maxillofacial department was extremely interesting. Mm-hmm. So from first week of dental school, that was my aim. What would you have to do to be able to enter a residency, and what kind of different procedures are done in dentistry? So that's how I ended up in maxillofacial. But it has changed a lot in the last 30 years. Our training was, as you know, I encouraged my son to be a prosthodontist, not a maxillofacial. And one of the reasons is because the workflow of the maxillofacial is very different today. Before, it was all major facial surgery, TMJ, orthognathics, and such. But with insurance issues with medical and everything else, you became limited in who could afford those kind of procedures. And so to make a living, you had to do something. And extractions and implants and reconstruction became a good way to go. And literally, it was dumb luck that I thought implant dentistry will be the future of maxillofacial, at least. And so from day one, when my instructor said, come and teach, I created this from nowhere. It was no thought or anything, just ad-libbing a implant clinic. So Mondays was just implants at the hospital. And slowly over time, I brought in the restorative, then the laboratory, then the protocols, and it developed into a very strong implant teaching part of the residency program.
And if we go back to this time, we have to say this was not when implant dentistry was, let's say, fully established and fully developed. It was in its very early stage.
Right. 1983 was when P.I. Brånemark came to Toronto, and they had the first Toronto meeting where basically he introduced implants to the dental world, 1983. I graduated in 1990, so it wasn't very far. I did not attend the 83, I was too young, but after 90, this, was basically the beginning of implant world. And there was no such thing as study clubs. Nobody knew what a study club was on implants. So establishing a study club and just using common sense to know, to have a group together, to have a plan and somehow an organized way of learning was the way to figure this field out. And by grace of God, it worked out. It worked out well.
It's very fascinating that you're overseeing now more than 3 decades of evolvement of implantology. And maybe coming back to your teaching activities, I doubt that actually you were the one that profited most. I believe that also the other ones profited a lot. But maybe, Ed, were there some turning points in those 3 to 4 decades that really changed how you look at clinical decision making, and how did it actually also change how you taught implantology?
Yeah, the answer to that question is like yes and no. Most people expect the answer to be yes, there's major changes. But I think my mindset always was, I must have been a terrible child for my mother, because anything that's said to me, I asked the question, why? So from the beginning, why would you put an implant? How would you restore it? Why would you restore it this way? That was my mindset. So really in the last 3 decades, things haven't changed. If you stay honest and true to fundamentals, understanding why you're doing what you're doing, then things usually turn out to be quite predictable. But what has changed is maybe the tools, a more elegant way of doing something. Instead of drawing on a tracing paper on an X-ray to figure out what size implant you're going to use, now you have a three-dimensional digital workflows and animations and such things. So it is allowed maybe teaching to be easier, more user-friendly, but at the same time maybe makes the student a little bit lazier because they expect the machine to figure it out when the machine is as good as its user. So
yeah, that's a good point, and we probably will have the chance to touch upon, let's say, the digital evolution a bit later on. You say that a lot of the things actually stay the same, but still, if you look at the last 3 to 4 decades, particularly when it comes to full arch rehabilitation of severely atrophied maxillas, there haven't been, let's say, from the get-go, all the tools available.
Right.
So maybe can you elaborate a bit on, was there an early point, and you said you were very fascinated by the oromaxillofacial surgery itself, but was there a point where you said, there is a chance to do things graftless?
Yeah.
So let's start to use specialty implants?
Right. Well, actually, the treatment of the edentulous severely atrophic maxilla was probably a major turning point. In the past, the way to reconstruct the severely atrophic maxilla, the way we do it today with zygoma implants, for example, used to be with major grafting.
Exactly.
And the major grafting was actually quite difficult because the graft had to be prosthetically driven, if you will. But that idea of prosthetically driven wasn't well understood. So a lot of people did not do it. So a lot of patients did not have their severely atrophic maxilla reconstructed. And then one of the ones who chose to have it reconstructed by grafting, as most people know, you cannot put a denture while the bone graft is healing. So the patients had to go without a denture while the graft was healing. For some reason, majority of patients are females, and to be able to ask a female to go through a major grafting and not wear teeth for 6 months or 7 months prohibited the treatment of many of these patients in private practice. In a university hospital setting, it was a different clientele. But in private practice, there was a void treating the edentulous maxilla. So with the introduction of zygoma implants and the graftless concept, not only it allowed treating these patients with less invasive techniques, but allowed you to let them have their, at the time we didn't do immediate loading. First it was two-stage zygomas, right? But at least they could wear their denture. And then with the evolution of immediate loading, you could go ahead and put the implants in and give them a fixed prosthesis. And even better, the next evolution was a terminal dentition, where you could extract and put the implants in, whether it's zygoma or tilted, and give them a provisional. So allowing the patient to basically be functional and socially acceptable during their treatment is a major evolution in being able to treat a lot of patients.
Can you draw your personal picture a little bit on how did you actually get to treat your first zygoma case? I mean, from what we see today and from where, in the 90s implantology was, there is a long way. And how was your personal journey to this, treating those kind of very complex cases?
Yeah. I was very lucky to meet Professor Brånemark, and very lucky that he actually took me under his wing and was mentored by him. So I spent a lot of time with him. Doing the maxillofacial implants for cancer patients, the eyes and the nose, the zygoma implants, because the zygoma implant began with the maxillectomy patient and the oncology patient, and then it evolved into the intact maxilla. So being able to be mentored by the man who invented it, not only just the hardware, but his influence of the mindset of the clinician. Why are you doing what you're doing? The empathy for the patient and knowing that you're doing all of this to take care of a human being is what I learned from him. So that was my biggest luck, and my biggest learning was being able to spend a lot of time with him, going to Brazil 3-4 times a year and just working with him and absorbing everything that he had to do.
When was the first zygomatic implant actually that you placed?
1995, I think. Yeah, the 96 was the first year we brought it to the North American market, and actually trained a very select group. And in 97 we met in Spokane, Washington. Kenji Higuchi was a maxillofacial surgeon that met PI in Germany when he was in the army, and that was the connection of bringing PI over. And we trained about 20 maxillofacial from all over the U.S. And it slowly began. It was not well accepted at the beginning because it was just different. The idea of immediate loading, full arch rehabilitation, fixed prosthesis was like foreign. Everything was removable. There was overdentures, whatever. It was very different mindset. Like today, everybody wants fixed. Everybody wants it right now. But it was not the case then. And some people at that time thought my first presentation of the zygoma at the American Association of Maxillofacial Surgeons meetings.
Raise some eyebrows.
People raised some eyebrows, like, who is this guy? Yeah.
And I can imagine.
Yeah.
I mean, if you look at the tools and classification principles that are offered today to clinicians, I think it's a totally different, I would say, baseline that we have, and it's much easier also to probably start. One of the things that we should quickly talk about is also your classification, Bedrossian classification in terms of zones. So you developed this concept of 3 and probably 4 zones that was later added. That says, well, if there is bone or if there is no bone, this is how you should actually place implants.
Right.
Is there enough bone for straight implants? Should you tilt them, etc.? And also, you're very strict in terms of position of implants, number of implants, and splinting, which all I think comes then together as a concept.
Right.
Can you elaborate a bit on how you came to the Bedrossian classification zone, and you use still today the same classification?
Yes. The way it kind of came about was, I think most people will relate to this. When you are in the middle of developing something, you going with the flow, but you don't see how you are systematically going through it, if that makes sense or not. One day, we had 6 a.m. to 8 a.m. treatment planning sessions at the residency program. For some reason that morning, we had some guests who were sitting behind my residents and I, and my resident was presenting. And he was not calling it zones, but he was talking about it. And the guests were like, ooh, that's a great way. I could hear him saying that, but I ignored it. By the 3rd or 4th time, they said, ooh, that's a nice way. I turned around and said, what's a nice way? They said, you have a very systematic way of looking at these patients. I said, really? And anyway, so when
Is not everyone doing it like this?
Yeah, and then when they left, when it finished, the rest of that day, I looked and I said, oh my God, there is a systematic way. So to be able to communicate it, we came up with the zones, and then the FP1, FP3. We came to a transition line. All of those things now that was in our head that we were just automatically doing it, we line itemed it, so it became a protocol. And again, it doesn't change. I mean, fundamentals don't change.
It's anatomy.
It's anatomy. It's the same thing. So it's the same. It's true as it is true today. Whether you're using digital or analog treatment planning, you're using the same fundamental principles.
Maybe to follow up and also link to the digitization. Your concept was based on panoramic radiographs, and now a lot of people have the possibility to access cone beam CTs, 3-dimensional data.
Right.
Can it be easily translated?
Yeah. Well, everything has its own place. The zones, excuse me, is for looking at it. So you have a atrophic maxilla. The first step is to look at a 2-dimensional radiograph. Depending on the zones, you decide whether it's tilted concept or it's zygoma or it's axial implants. So that's your initial guess, let's say. This is what I'm going to do. To confirm you can do it, you need to make sure that there's enough volume of bone. That's where the 3D
comes in.
Radiographs come in. And then the ZAGA classification is a very nice interpretation of the 3D anatomy, which basically tells, the ZAGA concept basically shows you, or makes you look at the lateral curvature of the maxillary wall and the degree of medial resorption of the alveolus. So if you are not very much resorbed and you are a convex lateral maxillary wall, you're a ZAGA 0. If you are a very hourglass maxilla with a lot of medial resorption, you're a ZAGA 4. So by using the zones is a 2-dimensional radiographic interpretation, whereas the ZAGA is the 3-dimensional radiographic interpretation. So it allows you to know, because without remember, when I was doing zygomas, cone beams and CTs were not that available. So we were going off of 2-dimensional radiographs and then intra-op anatomy and surgical knowledge. So whether the middle of the zygoma implant was inside the sinus or outside the sinus, you recognize that during surgery. Well, with the 3Ds now being readily available, knowing that the ZAGA concept of looking at the radiograph is a way of evaluating, you can preoperatively already know whether you're going to be in the sinus, out the sinus, or not. So it's just the digital workflow allows you to see things and maybe practice the surgery in your mind on the monitor before you actually get to it.
So beyond this classification, which became pretty much the standard way of looking at these cases and selecting the basic implant concept, what is your guiding concept today when you're placing zygomatic implants, when you approach your own cases? Or to phrase it differently, what is the concept you're teaching learning clinicians that you do very often at?
Yeah. Well, my entire basis of thinking is based on biomechanics. No matter what you do, it's very nice to, physically do it, but this is not a static situation. There's occlusal forces that are being placed on whatever it is that you're reconstructing. So, for example, on the zygoma implant, all the literature and the systematic reviews and all the protocols that have clearly demonstrated this to be a very predictable procedure is based on what I call quad cortical stabilization, stabilizing the zygoma at the alveolar ridge and at the zygoma. And all the literature, like from Frank Renoir, shows that it's the first 6 millimeters of any implant, whether it's tilted, zygoma, axial, that takes all the forces. So the engagement of the implant at the maxillary alveolar ridge is critical. So once you know that, now you adapt the patient to, you try to get give the best biomechanical surgical procedure to your patient. And if the patient is totally resorbed and you cannot engage the alveolar bone, then you know you have a biomechanical limitation, and you just advise the patient, for example, please don't bite an apple rest of your life. Not because, the misconception is you can reconstruct severe atrophic maxillas and have that patient function as if they were normal.
Fully functional.
Yeah,
That's
you
not-
can't.
That's not the case.
It's very similar to somebody who is an amputee. They're amputee from their hip down. They have an artificial leg. Well, you cannot. I'm sure there are Olympic athletes that have an amputation, but that's not the norm. That's very exceptional. So you have to. It's our job as clinicians to educate our patients on the existence of their anatomical defect and the limitations of their reconstruction.
So what are then some of the design principles from a prosthodontic perspective?
Yeah.
What is it that you're teaching there?
Well, simplifying, when you have command of a subject, you can explain it in a very simplified way. Everybody talks about loading. Well, what does loading mean? It's centric occlusion and lateral excursion. Well, whether you have 4 implants in an arch or 16 implants in an arch, it's the first and the last implant that take all the loads. If you have a cantilever, you double the load on the first and the last. So it doesn't matter if you have 16 implants, you're doubling the load on the terminal implants. So you try to maximize your anterior-posterior distribution for the purposes of eliminating cantilevers, for no other reason but that.
Exactly.
And then so once you understand those prosthetic load distributions, then you can modify the number of implants and distribution of implants to meet that criteria.
On that topic, I wonder, how is the collaboration with your son, Armand, changing the game for you? What is it that you learn from him? Because he's a trained prosthodontist, right? Has a bit of different focus and a bit of different background. And, what are the topics that he would come to you and ask you for advice?
Yeah. Like all father-son relationships, he has a lot to teach me. No, he spent a lot of time with me since high school on vacations and everything. So he's seen all on-fours and zygomas evolve as my assistant. He would spend a lot of time. So he's understood these concepts. He saw the analog conversion. And then when he went to prosthodontics, he went in there with a lot of knowledge. And then obviously the program he went to, University of Washington, is one of the best in the country. and they teach him the basics extremely well, and he has a very critical mindset, and very, very, he jokes around saying, you know, you used to get mad at me for playing with video games. See how now it pays off in
Yeah.
digital things?
Oh, this is what we also
Yeah.
hear.
Yeah.
Yeah, exactly. We hear this all the time.
Yeah.
So,
So he is exceptionally quick and understands
Yeah.
and can figure his way out on ExoCAD, on co-diagnostics, whatever the program is. So I am very happy to have him do those things for me. He's not very happy to have me ask him to print my models for me and do this. But no,
It's a give and take,
it's
so.
a lot of fun, working together. And the best part, because we again are of the same mindset, and it's I say A, he knows I'm saying apple. I say B, he knows I'm saying whatever. So we do things without too much of a problem.
yeah, not only this in practice, but you're also teaching together and lecturing together.
Yes,
I
yes, that's
imagine.
incredibly. Last week we were at the American Academy of Fixed Prosthodontics, and we presented, zygoma implants from the patient treatment perspective. But he presented the RevX and the Exact and the photogrammetry, the three different ways of making the final prosthesis, and the audience seeing. We did a smile in the box. We did a axial implant. We did a zygoma, different three patients, and for the audience to see, the clinicians to see the different surgical approaches, different patients, and then the three different ways of doing the digital final prosthetics, just shows that, hey, you can actually seamlessly work with a colleague and everything just makes sense from A to Z. And hopefully they can form teams like ours,
And you're also publishing together. There's a book that you published together, the Immediacy concept, also together with Larry Precht, that I think you for many
Yes.
years collaborate very
Yes.
closely with. What's special about this book, the Immediacy concept? Because it was published in 2022, and I know you embarked on this field of immediacy very early on.
Yeah.
So what's special about this book?
Well, again, people who know me, they know that I'm very honest about why I do what I do. The BLX implant is by far the best designed implant right now, especially with initial stabilization, with the loads that are being placed on a non-osseointegrated implant with immediate loading. So what we did in that book is made sure that all the science of bone physiology, contact osteogenesis, distant osteogenesis, the surface, like the SL. Why is SL active the best surface? Not the best surface because somebody just says so. You have to scientifically show that it is and contrast it to the next one that is not. So we have all of that information in the book. We have all the information about the protocols for example, aesthetic evaluation. What are the criteria to have an aesthetic anterior implant? Simplified, like placed. We talked about different implants when you would do the zones and when you tilted versus zygoma, and then once you have described the hardware and the science behind it, the rest of the book starts now putting it together. So this is how you treatment plan from a prosthetic point of view. This is how you do. There are chapters on how you do the surgery, and then there's chapters on how you do the corrected cast and the final prosthesis. So that book is, really the Bible of immediacy. Not because we wrote it, but I asked many of my colleagues who are really the leading people in the field to contribute chapters. So Larry, Armand, Panos, Kostas, Ed Char, a lot of people, Danny Boozer, a lot of people have chapters in there talking about the TLX, BLX, giving all the information. So it's basically a consolidation of all the scientific literature that's there, written in a very clinically applicable language. So you can read it and know why you're using it.
So a book very worth reading. What do you think is the importance of mindset if you approach immediacy?
Yeah. The mindset is treating your patient well. If your mindset is taking care of your patient, then I think automatically you start looking for predictable, you start discriminating the literature. You don't do things just because it's sexy and it's what everybody is talking about. You ask the why question. And once you understand the protocols, then you learning how to do it for most people, I think, is easy. The hardest part is knowing what to do. And once you understand all those, your mindset becomes, I think, wholesome, and your outcome becomes predictable. But if you're doing things hoping that it will work, that's the wrong mindset. Yeah, because the answers are there. Going a little bit back into our conversation earlier, you said, like, what have I seen evolved in my career? The first, it's funny because it's 3 phases, and I've been doing it for 30 years, so it's like 3 decades, but it just matches perfectly. So when I graduated, it was the era of hoping that the piece of metal would stick to bone. So,
Hoping.
yeah. So if the implant was solid, it didn't matter what angle it was in. So it was all surgical based. Then we realized, oops, it does create some prosthetic issues. So the second decade, in the 2000s, it was the era of understanding biomechanical forces on the implants, understanding how to place the implant so it could be actually restored. And I think the term prosthetically driven was evolved
Coming
at that
up, yes.
time. It's a very old term now. I mean, everything is prosthetically driven, but at that time, it had a significant meaning. It meant don't put the implant cockeyed, because that's not the right way to do it. So it was that. And then the next decade became the very generous, hopeful, soft tissue management things, which kind of faded away because we figured out that you can only do so much with soft tissue. So what basically happened over the last 3 decades is we understood bone, we understood prosthetic forces, we understood what overloaded the implant. So the implant number, distribution, angulation, all that was perfected. So today we really have a complete understanding of implant reconstruction, and it's not everybody looks at it as if it's just the surgery. If I can relate it to building a building, the architect's drawing is critical to the foundations man's design of the foundation. And the foundation and the architectural drawing and the supports and all that go together, and how it resists wind and whatever. So it's the same in the mouth. The prosthetic fundamentals, the surgical fundamentals have to match, and you have to make sure that they amalgamate together, and then your outcome is predictable. It's not by accident.
Maybe to close this chapter, and then we move on to digital, which you also covered in your book.
Sure.
How do you explain the question that we get very often from people that feel still today, immediacy, zygomatics, and all of those treatments are kind of aggressive and risky after all those years and the evidence we have? How do you explain this?
Well, I mean, I kind of understand it, and I don't. That's what they said about implant placement in the first case. When I was placing delayed implants in the molars, not immediate, even delayed, the other university in my town was like, what are you doing putting implants in a molar? You're crazy. I mean, that's on single implants, healed sites, which today is the gold standard for somebody who's beginning to do implants. That's the most predictable, easy things to do. So I understand fear and anxiety comes from lack of knowledge. And once you have the knowledge and you understand how it works, the fear and anxiety goes away. So it's respectable. I respect people who are being cautious, but yeah. So it's just understand it. The literature is there. If you have a question, ask the question, we'll give you the answer. It's not like before where we were not sure what we were doing. We knew always what we were doing, but we couldn't back it up. Now with the data is available. The immediacy is over 20 years old, 25 years maybe even. It's not a new concept, but more and more people are being introduced to it, and more younger people are coming. And I would like to see universities teaching it more. Then the young people coming out will not be so surprised and so scared because they would have already known it. So if we can emphasize it in schools, curriculums, and have the faculty know about it, therefore teach it, then that anxiety level of the new graduate will be less, and hopefully they will accept it. But it's definitely, it's not an experimental procedure, which a healed implant was considered 30 years ago.
No.
Yeah.
I mean, case selection is still important, but
Well, yes. I mean, you could know all the right rules and apply it incorrectly, then
exactly.
you will that. Yeah.
Yeah.
So case selection, basically, treatment planning. If you were to ask me what are the phases of treating a human being with implants, it's treatment planning, surgical, prosthetic. It starts with treatment planning, but everybody starts with either surgical or prosthetic. Right? It's backwards. No, it's all with the treatment planning. If you treatment planned it, you basically case selected it. You know in the treatment planning process, this is not appropriate for this patient, therefore you eliminate it, and that's called case selection. So it's all about treatment planning, but the genes of a dentist is want to do something.
Bias to action.
Yeah, it's we are very mechanical. We want to do things, but if you do it with the knowledge, then it's predictable.
Yeah, we're talking about the architect, basically. First on paper, let's plan it before you build the fundamental.
Yeah.
So let's switch gears a bit and talk about digital and also the future of dentistry. And we already touched upon it a little bit, but how has digital planning actually changed the way how you approach these complex maxillary cases?
Yeah.
And are there some tools that really, in your view, changed the outcome to the positive? And are there other digital tools that actually is maybe creating overconfidence?
I address the overconfidence part first. No digital tool substitutes your analog brain. The digital tool is as good as the person using it. Like a computer is good as the person inputting the information. So that's the bad part, where you may get this false confidence, thinking that the machine is going to think for you. But if you are a true believer of fundamental concepts and you know it, digital tools are fantastic. In maxillofacial surgery, when we do Lefort 1 osteotomies, the way we used to do it is we would get stone models, mount it on the articulator, cut the stone model, section it, and then with sticky wax, move it to where it's supposed to be, sticky wax it, and that was called model surgery. You said, I'm going to expand the maxilla 5 millimeters, I'm going to bring it forward. So you cut the model, you expanded it, you added wax, and you said, yeah, that's a good idea, or I should expand 1 more millimeter. Well, today, you don't have to do model surgery. You can actually print the patient's skull. You can do the zygoma surgery or the model surgery as many times as you want. I was going to do it this way. Oh, no, I want to move the platform further back and get a bigger AP distribution. You can do it on the same model, or you can very easily print another model and do it. So it allows you to do the surgery as many times as you want. So when you go to do the surgery on the patient, there's no surprises, and maybe you've even made a better decision than you initially thought. So it just makes you a better clinician.
Are you using today, with your hands and I would say experience, also these type of technologies to prepare yourself for surgery, or is it something that at one point you don't need it anymore because you have so much experience?
Well, I always did these cases without it, so I have the experience. I don't need it, but the fact that I can have a son who can print it for me
makes it attractive.
Makes it quite attractive to have it. And I think it would be false to say even the day you think you're that good is the day you're going to make the mistake. During the surgery, you are done when the last suture goes in. From the beginning to the last suture, even the best experienced person can make the most worst complication. If you're not going into surgery with some kind of anxiety, knowing that you can mess this up, I think it's a wrong mindset. You have to go there saying anything can happen. So you are you're concentrating, you're not thinking of other things, you're not joking, you're doing everything perfectly, knowing that you can mess it up. So if you have the opportunity, even as an experience, I have right now on very difficult cases, quad zygoma cases or such, I will print a model and I would basically confirm what I was going to do was the right thing, or tell myself, maybe I could move this, or maybe. So no, it's a one. No, you cannot be arrogant. Having a model surgery is definitely going to add to your. But I have one thing just for fun to tell your audience: don't make the mistake I made. I had 1 week, 3 cases. I printed 3 models. For efficiency's sake, I had the camera, because I take pictures of it to use for my lectures. I set up the cameras. I took pictures of all 3 cases, and I did not write down the nuances. No, the nuances of each one. The next day, when the first surgery came, I couldn't remember what was the nuance on this one because, So even if you have 3 cases back to back, do
Separate
a model
them.
surgery on one,
Proper.
finish that, then do the model, because then what you did stays fresh in your mind. Yeah, you can sometimes be overly efficient and.
So linking also, the digital planning to the patient. What's your thought on guided surgery? So guides for regular implants, but also guides for zygomatic implants.
Yeah, well, there is a guided, truly guided zygoma. Truly guided. Guided means the drills are guided, the implants are guided, everything is guided. That exists. Myself and 2 other colleagues in 2007 to 2011 actually did an FDA challenge on that. Where in my first book, Before the Immediacy, I have step by step of that instrument. But for some reason, that instrumentation was shelved because it was too early. We did it in 2000, and most people were not even thinking zygomas. But it does exist. It doesn't exist today. The guides that are being done right now are basically the initial drill. The rest of it is all freehand. So it would be very nice to have a true guided, because I've done it. It works. It's very nice. But in single implants and in pro arch and such, guided surgery is very nice. It's really an advanced procedure. It's not for whereas people think it's for the beginner. For you to do guided, what it robs you from is the tactile sensation
feedback,
and you're not seeing things. Even with navigation, even with robotics, you are not engaged. You are hoping that this thing. So it does take away some of the tactile sensation. But my message would be, if you're doing guided, you must be able to do analog if the guide drops, if the guide breaks, if something doesn't work. If you can't do that, then you yourself are in a bind. And I would never teach somebody to do guided and knowing that they don't know how to do analog. So it's like a computer versus a pen. It's a very elegant way to do something, but it has its drawbacks. Guided is not as accurate as we think. If it was, then why aren't the abutments prefabricated into the prosthesis? Because the deviation in XYZ is picked up in the direct picking up of the abutments in the mouth. So as long as you know that, then you make fair statements. Guided surgery is a very elegant way to do it. If you choose to do it, fine. But to say it's the best way, it's the most accurate way, it's not true. So, again, we go back to fundamentals. Know the fundamentals, and then if you want to use a guided surgery, it's absolutely fine. It's very nice.
You're also in a lot of editorial boards, and you have seen knowledge expanding, but also maybe change in certain ways. What is one trend that you're quite excited about, and maybe what is one trend where you think it's overrated?
Well, again, like I said, the wording of articles, like for about guided surgery, where it's the best, it's the most accurate. Those are not fair statements, because I try not to make absolute statements, because an absolute statement means if you're not doing what I'm saying, then you're doing something wrong. I would not want to put somebody else in that position. I like doing analog surgery because that's what I've done. It's faster. I can do it faster. I can do it whatever, but that's me. You want to do it guided? That's fine. 4 implants biomechanically is enough. You want to put 6 in? Okay. You want to put 10 in? Now I kind of look at you and say, why? But I don't say it's wrong. But to say 4 is inadequate, that's the trend that, I wish that in the literature we continue presenting true information, not getting too excited and saying 6 implants or doing this, So as long as the literature stays honest, and then as we get more complicated, digital, as the treatment of the fully edentulous patient or the severely resorbed patient with the zygoma becomes more popular, more and more people are writing articles and making statements. The reviewers, if the wrong reviewer looks at an article and maybe doesn't understand it and okays it, sometimes, and it has happened, things get in the literature that shouldn't be. So I'm a little worried about advanced surgery being reviewed by non-advanced reviewers. That would be my worry. But at the same time, I'm happy because advanced surgery is getting exposure. And the reason I'm happy is because as more clinicians know that quad zygoma, for example, is available, then if they don't know how to do it or they don't want to do it, they know how to refer it,
Exactly.
as opposed to not even knowing that's a
That it's
possibility.
existing,
Yeah. So
good. Yeah, that's an interesting topic on how to deal with peer-reviewed journals, etc. Now also that AI is coming in, and it's quite easy to write the text that sounds very convincing, but then you need to have someone that checks the fundamentals very
yes.
properly.
Yeah.
To look a little bit more into the future, so maybe 5-10 years from now, and we touched upon your father-son relation. So basically, he's already the next generation.
Yes.
What would you foresee for the severely atrophied maxilla in the next 5 to 10 years? And maybe what would you hope that your son or the generation of your son would do differently than we do today?
Yeah, I thought about it because, innovation has to go on, and there's got to be a better way of doing something. But sometimes my short answer to your question is not much else, but it doesn't mean stop looking for doing it better. What we're doing right now with the surgical reconstruction of the severely atrophic cases that could not be done before, what we're doing with the prosthetic rehabilitation that makes it very aesthetic, very functional, is amazing. The zirconia, the color, all the products and all their innovations are very nice. I mean, what we're doing with this severely atrophic maxilla is giving them teeth. It is. I know it's not heart surgery, but it's quite life-changing. It really affects the psychology of the patients. It's wonderful, with very minimal long-term issues. And the complications that we're having, screw loosening, zirconia fracturing, and if you really look at the why, it's misfit, it's overloading, it's some of the missing of the fundamentals. So what can we do in the future? Go back to the beginning, re-emphasize fundamentals, and you can make the stronger zirconia, but if there's a misfit, even the strong zirconia will fracture.
Misfit, yeah.
So I'm not sure. Can we put tooth buds and genetically grow teeth? Maybe, yeah, but I think we should look at innovation. But today, right now, what I see is continue on the industry support on modifying instruments and whatever it is that we need to be able to match the science that we know works, and having, again, industry facilitate meetings where the clinicians can come together and spread the news, because it's very difficult to get 700, 1,000, 2,000 people in one room and have a symposium without industry support. So yeah, continuing that is, and then as one genius comes up with a new thing that I'm not even thinking of, I'm very happy to entertain it.
Yeah, that's good. So that's a good bridge actually to our last chapter. We wanted to speak about you as a speaker, as an educator, and as a mentor. And I understood from the beginning that you've been actually an educator from day one.
Day one.
So you had 4 days in
Yeah.
practice, 1 day teaching. I would like to start with the following question. What is for you the difference between a good surgeon and a great surgeon in the field that we spoke about?
A good surgeon and a great surgeon. I think a great surgeon, just like an educated man knows how much he doesn't know. Once you think you know everything, that's the beginning of you
The
going
end.
down. So a great surgeon, thanks God that he was successful in doing the surgery, because at any moment things can go wrong. A great surgeon, just like a good surgeon, hopefully follows fundamental principles, treatment planning, and does everything right. And just recognizing that, you can make a mistake, and knowing how not to make it and being aware of that, and just being humble. And that's what makes the great surgeon, knowing that there's still room to learn. And getting into arguments, which I'm very good at doing, is is not a bad thing.
Yeah.
A debate, because I can learn a lot from you, and you can possibly learn from me. So debates are good, as long as you have a goal. The horizon is to come up with a good solution.
So what is the ideal way if I would be a young clinician and I want to embark on a journey that you and Armand on and say, look, I would really like to master these complex reconstructions and doing life-changing things to patients, especially in the atrophic maxilla. What for you is the best path for me to get there?
Yeah. It has to be in you. Part of the previous question was the great surgeon. You have to have passion. You have to have passion to do the right thing. It cannot be money. It cannot be, oh, look at me, I can do quad zygomas. It cannot be all of those ego things. You have to have the passion to do the right thing. You have to get satisfaction after having helped somebody, even if they didn't thank you. You have to know that, wow, this is a great service. Imagine if that was me, or imagine if my mother needed that procedure. So if you have the passion, and you just, your time will come. If you want to be an educator, if you want to be a speaker, if you want to be a role model for others to follow, then nobody went from 0 to 100 in 1 second. It takes time, and time is, again, educating yourself, knowing what you're doing, practicing, getting the experience. And just like everybody, just like me, have what I'm doing, I'm basically paying it forward. I learned from somebody, and now I'm not teaching anybody what I know. I'm teaching everybody what somebody taught me. And if you can keep that open mind and be humble and passionate, I think everything will just come into play.
What I find very impressive in the field that we speak about is that I still see very experienced surgeons and clinicians that are still going to courses and conferences all the time. They never stop learning. That's very impressive, because at one point you could say, look, you have seen it, you have learned it, and you know how it works.
Yeah.
But my impression is that these people, the greatest surgeons, that they always continue learning.
Yeah, because like I talk to a lot of my colleagues who say, why should I go? I know. And I say to them, if you learned one thing out of that 4-hour thing, it was worth it.
It's worth it.
And it could be the simplest thing. It could be the way your front desk greeted the patient before the surgery because they were so anxious, et cetera, et cetera. That kindness, that protocol that you have on greeting patients brings the blood pressure down during the surgery. Everything is fine. There's always something to learn. It's impossible. There's always also something to learn not to do.
Yeah.
So you see this thing, you go, oh my God, thank God I'm not doing it. But if you go in and you learn 15 things, you might want to go home and question, what is it that I'm doing?
Am I at the right conference?
Or am I doing the right thing?
Exactly. Do I have the right patients in my
Yeah.
chair? So thanks a lot. That already brings us to the end. And as usual, I would like to ask my colleague George, what stood out for you in this 50 minutes of exciting conversation?
A lot, actually, Ed. So I have a mental picture, basically, of your journey that maybe might be accurate or not, but I think for me, it's a good summary of the conversation that we had the chance to have. So I think for you, it started always with, first of all, you were very clear that you wanted to become an OIF surgeon from the get-go. And I believe also this mindset, having the right mindset was very important. And we just discussed about the importance of putting the patient first. And the second thing that we just discussed is about the passion, passion for doing the things right. And I think this then also led to a lot of systematic thinking that, you look into literature, you try to analyze and distill the essence. You're good at also creating then some recipes that others can profit from. And that actually, we talked a lot about these fundamentals that are there. But at the flip side, you also need to have this openness to constantly also questioning, let's say, these fundamentals and learn new things. And that brings me to this last point, which I think you're very passionate about, and I didn't know, but very fascinating. So from the get-go, you started educating and you dedicated a day per week, which is a lot, to actually bringing what you learned to other people. And this combination, I think, of critical thinking, having the mental capacity to break down complex topics into something that people can take away. I think that was, for me, a great highlight of the conversation.
Very well summarized.
No,
Thanks a lot.
thank you. And I want the audience to also know that although this is a Straumann podcast, working with the right team, including commercial, is very important. I mean, I use the Straumann products, or I use the protocols, or I help develop the protocols. You can have the right protocols, but if you don't have the right tools, you don't have the right support, you don't have the right, like we talked earlier, T&E that allows to bring all these clinicians together, then we are working in little silos. And being able to provide this in the US or globally, it's very helpful to my profession. So I want to thank industry, you guys, for creating this podcast or everything else that you guys do, because it's very, very important.
Thanks a lot for the feedback, Ed. And I think that's close to our heart, that we support you in a way that you can focus on what matters most, and that's treating the patients, and you don't need to worry left and right about support and this stuff working. But we try to make this happen for you. So thanks for joining today for the conversation. Really loved it. Loved the energy of it. And to our listeners, if you loved the episode as much as we did, if you learned something and it sparked some new ideas, then please recommend it to any colleague that you might think of. And otherwise, please continue following us on Apple Podcast, on Spotify, on YouTube, wherever you want. And we are always happy to have your feedback. Please drop us a direct message or interact with us on Straumann Group Instagram channel. So thanks a lot for listening in, and see and hear you next time. Thank you, Ed. Thank you, George.
Thanks.
Thank you.